Good morning, all. Thank you so much. I very much appreciate you guys all being here and taking the time. For those of you who have not met me, my name is Matt Robinson. I'm the CEO of the Physician Association of California. We're thrilled to have you here today in the state capitol for our symposium, Protecting Private Practice, Maximizing Benefits, Overcoming Barriers. We launched this association earlier this year to bring a solely dedicated voice to the state capitol that is only advocating on behalf of independent practices and small practice groups. While our goal is to protect and enhance private practice, we will work with all healthcare stakeholders, policymakers, and groups alike, but to make sure that private practice has a seat at the table. Throughout the symposium today, you will hear from my wonderful lineup of panelists. We have physicians from up and down the state. We have a leader in patient advocacy and a healthcare expert. All these panelists will discuss with you the various benefits that private practice has, but also the various barriers that they face. You will also hear that private practice physicians are in their mode of practice because they love doing what's best for their patients. They want to preserve the patient-physician relationship. After the two panels, there will be an opportunity for the audience to answer a couple questions, and we appreciate you keeping it directed to the panelists on the panel. At this time, I want to introduce Assemblywoman and Majority Leader Cecelia Aguiar-Currey, who represents District 4. I've known the Assemblywoman since she came to the Capitol in 2016, and I also call her a friend. She's very personable, she's available, she's sincere, and she's very thoughtful. And that is even more so obvious if you ever have the opportunity to meet with her in the district in her hometown of Winters off of Main Street with all the people that come up to Cecelia and ask her many questions. So at this time, please welcome Assemblywoman Cecelia Aguiar-Currey.
Thanks, Matt. Whoa, this is kind of high. How's everybody? Well, thank you very much for having me. Can I adjust this a little bit? Thank you. It's a pleasure to be here. I'm Assemblymember Cecelia Aguiar-Currey. I'm currently the Majority Leader of the state of California. I'm really excited about that with the Assembly. And I'll be serving as the chair of the California Legislative Women's Caucus. It's a bipartisan women's group that would do really fun and exciting things, and we care about our families and our communities. So my 4th district is a rural district. I have Yolo County, Colusa, Lake, Napa, and parts of Sonoma. All wonderful places where I depend upon health care in my district, like everyone else. So I just first of all want to thank you for coming to the state capitol. I really just realized how beautiful this building is because they've been slowly remodeling the building, and this is a delightful room now. It's got better bones, it seems like. And I want to thank the Physicians Association of California for including me today, and to my good friends John Latimer and Matt Robertson for their help and their support. So we're gathered here today, I feel like a preacher, so we can learn more about the importance of private practice physicians in our communities and the challenges they face to maintain their practice. And I really can relate to this. The reason is because I lived next door to a doctor for years. And his name was Dr. Young, and we also called him Dr. Butt. And the reason we named him Dr. Butt, because I used to answer the phone when I was young, when I was 10 years old, when he and his wife would go out to dinner, and we'd string the telephone line across the fence, and I would answer the phone, and they would always say, is the doctor in? I go, no, he isn't. Well, I need to talk to the doctor. Yeah, Dr. Butt, can he call me back? And so we all called him in the neighborhood Dr. Butt. So because my district is small, is relatively with small cities and towns, I focused a lot of my energy on in my first 8 years on trying to help gain more access to many things, whether it's healthcare, transportation, anything that helps or we have to deal with in underserved communities. So in Winters, where I am, we still have an independent family and specialty doctors that are well known throughout the community. They have relationships with their patients that go far beyond the practice. And as you know, it's all about trust in small communities. We want to know who's taking good care of us. We want to know that they know our families as well, they know our history. So they're a huge part of our community. And they are very thoughtful because they trust us. They trust the healthcare professionals in our town. So some are specialists providing high caliber care to patients when their health needs are beyond what a family doctor can do. Unfortunately, it has become harder than ever for these physicians to maintain their independence. As larger healthcare systems move to buy out small practices and consolidate care, many private practices have a hard time competing. They struggle with the many pressures that come with running a business while providing patient care all at the same time. So I understand that there's tons of financial regulatory challenges these doctors face while running their business. When my dad passed away, I had to take over the paperwork for our family farm, and I was shocked that all the things we had to do to maintain our business and to try to continue to keep it afloat. So while most Californians are insured and have access to health coverage, the volume focus of health plans managed to make it harder and harder for private practice physicians to spend the kind of time they want with their patients. The association hears a growing amount of frustration from their member physicians with health plan requirements for prior authorization and utilization review. These policies may be well-intended, but sometimes they interrupt the delivery of care from a doctor to a patient. And because of low reimbursement rates and paperwork requirements, it has become nearly impossible for these physicians to see their neighbors who rely on Medi-Cal for their health care. So I look forward to working with you and the association on these issues in the new legislative session. We need to find ways to support our medical professionals in rural and underserved communities. And private practice physicians who choose to own and operate their own practices are an important part of the system and an important part of our communities. So I'm so glad the Physicians Association of California has been established by these very same physicians, so they can collaborate to support these practices and the patients that they treat every day in communities like mine. So today, you'll hear from several of these doctors, along with a patient advocate, an expert in health plan contracting, and all of whom to share about the benefits and barriers to private practice. I really wish I could stay all day. And the reason is because in my rural communities, I go and visit the doctors and I visit the hospitals, and what they're looking for is so hard to get now. And I've sat down with doctors that are saying, I don't know how I'm going to survive. And I had one of my best friends is a doctor, and he's with a larger group, and he told me he was going to retire. And I said, Dr. Steven, why would you do that? You're so good at what you do. And he said, I can't continue. I can't keep up with the paperwork. After I get done with a patient, I still have a lot of other paperwork to do. And so I said, well, you need to tell your story. So they didn't want him to retire, and so they finally gave him a transcriber. And I thought, well, that's good. And he said it had changed his view on how to get things done. And then he said, so I kept that in the back of my mind, and I just met with some physicians last week to talk about rural issues. And I brought up, do you have a transcriber? Would that make your job easier? And they said, we're moving to AI. And I thought that was pretty darn incredible. As long as my privacy could be taken care of and the data was secure, okay. But we don't want to lose our physicians. And on our rural areas, you really have to love the area, right? When I do stuff in Lake County, I was trying to bring more family practitioners up that way, and they would say to me, well, it's fine, you can do incentives to get someone up in these rural areas, and the physician likes the area, but the wife who's lived in San Francisco or Boston and LA, they don't want to be in my rural areas. So it's always a big fight, and I really appreciate what you do because it's so important to have access to health care for everyone. So just as a reminder is that when you come over to that Capitol, we have a health committee, and you can always visit with our committee members and tell your story and why it's important. I'll be your voice at the podium. I always am, because I'm on the health committee. I always try to find out what are the unintended consequences of the policy that we ask for our constituents to do. So please keep that in mind. Please keep in mind 3 things that I always do. What's the problem? How do we fix it? And the most important, how do we implement it that doesn't harm our constituents? So thank you very much, and thank you for having me today.
Good morning, everyone. My name's Alan Young. Let's hear it again for Assemblywoman Aguiar-Currey. That's a great presentation. I am the interim host of the show Inside on Capitol Public Radio. It's a total honor to be serving as your moderator today. Quick reminder to please put your phones on silent if you haven't already. And with that, let's introduce our panelists. Dr. Join Liu is a private practice radiation oncologist based in Eureka. He serves patients in rural Northwest California and Southern Oregon. He's the past president of the Northern California Radiation Oncology Society, as well as the California Radiological Society. Dr. Liu currently serves on the Board of Trustees for the Radiation Oncology Institute and the Board of Chancellors for the American College of Radiology. Dr. Liu, we're happy to have you.
Thank you.
Our next panelist is Lynne Kirst, the executive director of the Hemophilia Council of California, where she advocates for communities experiencing bleeding disorders and rare diseases. In 2024, under Lynne's leadership, HCC advanced access to care statewide by launching the California Rare Disease Access Coalition. As a Sacramento native with personal ties to the hemophilia community, Lynne brings extensive nonprofit and public service experience to the Hemophilia Council and to this panel. Thank you, Lynne. Finally, Dr. Omer Deen is a board-certified internal medicine physician specializing in digestive disease and clinical nutrition at Deen Medical Group in Torrance. He has served on the executive board of the National Board of Physician Nutrition Specialists, and he's a past president of the Los Angeles County Medical Association. Dr. Deen has published extensively on topics such as obesity, stroke, and inflammatory bowel disease. He is the current chair of the Physician Association of California. Dr. Deen, welcome. We're going to start by exploring the distinct benefits of private practice for both patients and providers. Dr. Liu, we're going to start with you. Can you give us 2 or 3 sentences about your role and responsibilities, and then tell us about the unique advantage that private practice offers patients in rural or underserved areas compared to our larger healthcare systems?
Sure. I'm a radiation oncologist in a private practice up in Eureka, California, which is, I'm probably the northernmost person of California in this room, about 5 hours north of San Francisco. It's fairly a health professional shortage area. I've been there for 17 years. We're in a 4-man practice. For about 9 years, it was just 2 of us. And as our practice expanded, we grew to 4 members. One of the benefits I see with private practice and being independent is the accessibility that patients have to reaching their physicians. Although I joke that I'm the physician that you never want to see because I take care of mostly cancer patients, patients often needing to get a hold of their physicians often have to go through a long phone tree of automated messages before they can get through to a human being. And one thing I'm very proud of in my practice is when patients call my practice, a human being answers the phone and messages are automatically passed on to me so I can get to patients much quicker, giving me the flexibility to take care of them on a timely basis rather than waiting on the systems that are in place, usually that move very slowly in very vertically integrated health systems.
And Dr. Liu, Assemblywoman Aguiar had a really eloquent anecdote about being out there in winters or in Lake County and rural areas. What's the difference for patients in rural areas with access to private practice physicians versus larger healthcare systems?
Sure. Well, in rural areas, everybody knows everybody. So it's very easy to get a hold of your patients, patients getting hold of you. You feel like you're actually part of a community. And so one of the things about private practice is that you have skin in the game in the community because you're actually somewhat of a small business owner. So the likelihood of you staying for a few years and leaving is much, much less because you're invested in the community and you know your chief of police, you know your city council members, you know your school teachers, your superintendents. You are actually part of the community. And that's a very different experience from a lot of the doctors that are employed in large integrated health systems, because we have both in our community. I've seen the rotating door of physicians that come, stay, sometimes not even a year, and they leave. And so being in private practice has allowed me to be a pillar, a very stable entity within the community that patients can look to for their care.
Thank you, Dr. Lynne. Lynne Kinst, can you give us a short background on yourself and then talk about why patients with chronic or rare conditions value the care they receive from private practice physicians? So let's start with your background in advocacy.
Yeah. So I grew up as part of the bleeding disorders community. My dad had severe hemophilia B, so a factor IX deficiency of clotting factor, and that's my background. That's how I started. So I have a real passion for serving patients in the bleeding disorders community as a patient myself. And as someone who grew up and has really seen the amazing changes that we've had in terms of treatments for bleeding disorders, just over what would have been my dad's sort of natural lifespan when he was born in 1940. They didn't even know that there was such a thing as hemophilia A and hemophilia B. It was just hemophilia. And the only treatment they had was whole blood and plasma. It was the only thing that they could do to treat them. Today, we have multiple federally approved gene therapies available to treat hemophilia, along with many other products. So in the bleeding disorders community, we and I feel a moral obligation, honestly, to fight for rare disease patients. Many rare diseases have no therapies yet, but the advancements that are happening are phenomenal. And so the work that we do and the work that I do in patient advocacy is about continuing to advance the quality of that care and ensure that as we develop more and more therapies, that patients have access to them, whether that's medication, treatment options, surgeries, all of those things. And we all know, and I know we'll talk about it a lot more today, that there's a lot of barriers to patients being able to access those treatments.
Can you quickly just give us a kind of teaser on the difference of care someone might get with a private practice physician versus that of a larger provider?
Sure. So particularly with rare diseases, it can be very difficult to find the specialists that you need, right? Especially, we've already talked a bit about rural areas, especially rural areas. In the example of bleeding disorders, we have 10 hemophilia treatment centers. These are federally recognized special care centers here in California. None of them, of course, are in rural areas. You say, oh, there's 10, and you sort of think, wow, that should really kind of cover our state. You still have patients that could be 6-7 hours from a special care center, which is where, again, particularly in these rural areas, a private practice physician who's really committed to the care of their patient is, sometimes with those health systems, it can be harder for physicians to collaborate. I think that way they, in a private practice situation, they can reach out to specialists in other parts of the state, get, kind of counsel how to best treat that patient. That might be the only bleeding disorders patient that they have in their practice, but that doesn't mean that they can't get excellent care with somebody really committed to treating them and to giving them the best care possible.
Thank you. Dr. Deen, I'd love to hear about your experience treating complex conditions like obesity and malnutrition. How did you get into that line of work?
It's a long story, but I'll try to keep it short.
Okay.
So part of my training and my practice has really taken me all over the country. I've worked in emergency rooms, ICUs. I worked in Miami, upstate New York, San Francisco, Cleveland Clinic where I trained. And I found the thing that kind of drew me into the social aspects of medicine and the healthcare problems that we're facing is that I saw these common trends in the way medicine is practiced and the way patients are managed. Coming back to kind of what you asked me about nutrition, so I was overweight as a kid. So it was always a struggle for me. I started losing weight late high school. Just got really interested in nutrition and obesity, and at the same time, we're seeing this real rise in obesity in the United States. And what the real kicker was through my training is where I learned about obese patients that are malnourished, because those two things are not mutually exclusive. And that directed me to kind of the food that we're eating, the pesticides, fertilizers in the food, how we don't have nutrient-dense food. And so all of these things kind of led me into kind of my career path through digestive disease and clinical nutrition. And so that was on one hand. On the other hand, I'm looking at kind of the health disparities where, a grocery bill at Whole Foods will cost you a lot more than a grocery bill at your local grocery store. And the cheapest, medical term, crappiest food is the most affordable food. And so, especially through the financial downturns that we've seen during my lifetime, you realize how people are forced into these food deserts or forced into these places where you really have no choice. It is cheaper to buy Coca-Cola than it is to buy water, right? And so things like that have really directed a lot of, not just my practice, but the more of the advocacy work that we're doing.
And you clearly have that personal passion, and how is your experience different in private practice, and what kinds of conversations and approaches are you able to take that you may not be able to take in a larger healthcare system?
Yeah, it's a great question. I think, as my colleagues alluded to, there's a different, you know how when you notice how when you cook something, it tends to taste better than if you get it somewhere at a restaurant or whatever. It's kind of this thing where you've got a vested interest, right? You've got to, like, I make an omelet like on a Saturday morning, and I'm like, man, this is like the best omelet. I dare anybody to try this omelet, right? It's because I've put in my heart and soul into it. And that's kind of how private practice is. You call the shots, you set the rules, you hire the staff that you think is best for the job, right? So when I was at Cleveland Clinic, which is a wonderful institution, I loved being there, I was assigned a secretary, and you have staff and you meet them, and so we form a team. In private practice, it was just me, and then I interviewed several people for the various positions and picked out who I think would be the best candidate for that position, and so I assembled my own team. But it gives me a little ability to kind of gauge the community we live in, the patient population we see, what's going to work best, what are patients going to be more receptive to, and you flex on the go. Some of the harder, parts of practice are you run into patients who aren't able to pay, who don't have insurance. I really personally enjoy the ability to choose if I want to see someone for free. I can do that. It's my decision. Whereas in my past positions in employment, there's policy and that's it. And we don't see this insurance or that insurance. So that's one example.
Let's certainly circle back to that. I want to talk now about autonomy and personalized care. Private practice offers providers with significant autonomy, which can directly impact patient care. So let's talk about how this translates into better outcomes. Dr. Liu, can you give an example of how private practice gives you more control or flexibility in running your business and deciding the best treatments for your patients?
Sure. Well, one thing is I'm here today. If I was employed, I would have had to go through HR to try to get time off to come here. So that's one aspect of autonomy. But when it comes to patient care, it allows me to be flexible and nimble and take care of patients when something is needed to be done on a timely basis. I have the ability for someone, let's say like a hospitalist, a primary care physician, or a medical oncologist to call me on the phone and say, hey, look, Joanne, I've got this patient that really needs to be seen quickly. And my reply to them is usually, keep them there, I'm coming over, or send them over right now. I have the ability to do that. Whereas in other large integrated health systems, it's basically like, well, send a referral and we'll see what the next available appointment is. And it may be for 2 to 6 weeks before the patient can be seen. So that flexibility and that autonomy to run my practice the way I want actually benefits the patients and benefits us too in terms of our wellness and our ability to make a difference.
Sounds like a throwback in the best kind of way when you'd call up the doctor and the doctor would show up and you'd know the doctor and they'd help you out there right in your house. That's great. Lynne, can you share an example of a private practice physician offering more personalized care than a major healthcare provider for a patient with hemophilia or any other genetic disorder?
Yeah, so the most interesting example and observation that comes to mind, and this is really sort of in one sense something that the new therapies have illustrated in California. So in California, I mentioned our 10 hemophilia treatment centers. 9 of them are essentially clinics in larger institutions. They're in university hospital systems. And one of them is an entirely private hemophilia treatment center. It was set up as a private practice of a hematologist in Orange County. And one of the observations that we've had as gene therapy came on board just in the past couple of years, and this is a national trend as well as a California trend, every institution that were like the first to be able to deliver gene therapy to their patients were hemophilia treatment centers that were privately organized. Because, not because the physicians at those centers are more committed to their patients than the ones at the larger institutions, but because when it came to negotiating with payers and figuring out how they were gonna set everything up and how it was all gonna work, those clinics that were in larger institutions had a whole extra layer of a bureaucratic red tape and negotiations that had to happen. They were not only negotiating with the payer, they were negotiating with their actual institution to figure out, were they gonna get to do the therapy in their own clinic, or was that gonna get sent over to, an infusion center that was part of the hospital? And particularly with bleeding disorders and rare disease patients, these physicians, for the most part, have stay at these centers for decades of time. And a lot of them are whole life clinics, right? They'll see patients from pediatrics all the way through adulthood. They might have the same hematologist and the same nurse and social worker and physical therapist that are seeing them at this clinic for decades of time, right? They don't want to turn that patient over to someone else to now to treat them with this gene therapy and this new development. They want to follow them, the same patient that they've cared for. And so it's been interesting to observe how those independent centers were able to move forward more quickly than those that had to navigate those additional layers of red tape.
And how great for the patient to be able to build that trust over the years and just know that there's a reliable entity, a reliable person.
100%. Yeah.
Dr. Deen, what's an example of a physician independence or flexibility contributing to improved patient outcomes in your specialty?
I think a big part of it is, like you just mentioned, that you tend to have a little more time and you can devote time to patients without some of the pressures that we might have in other tasks when we're employed. You tend to know patients a little bit better. My patients have my cell number. And yes, every now and then you get calls that are probably unnecessary, but for the most part, people are very respectful. They're very grateful to have access. And they'll call you when there's an issue, or in my case, often text is easiest, so I'll get text messages, including early this morning, I got a message from a patient. It allows me, so what I don't have to do is have them go through a whole phone tree to reach me or to reach somebody who maybe is covering for me, who may not know the patient directly, right? It's kind of one of those, like, if this is a medical emergency, please hang up and call 911, right? It's often not an emergency medically, but to the patient, it is an emergency. I need this taken care of right now. And sometimes it's something as simple as a refill. Sometimes it's something that, I lost my medication and I need help, or I'm having this side effect and it can be managed relatively easily. Those are the types of things where we can intervene. And so I would say probably the strongest point would be what I hear from patients. And what I hear from them is that they like having that access and they like that things get taken care of so quickly, where they're not waiting for days. right? So that's one example.
What a huge benefit.
Yeah.
Thank you.
Yeah.
So let's talk about some of the business challenges and maybe some of the solutions. So running a private practice comes with its unique challenges, from operational demands to navigating regulations. Dr. Liu, what are some big challenges you face in running a private practice, and how do you navigate those challenges?
So one of the big things that made the news in the early 2000s was when Medicare was changing the way they were paying physicians. And some of you may be old enough to remember, but our payment system was based on the sustained growth rate formula, which was based on the GDP of the country. And that after the dot-com era, after that the economic boom that we had expired, physicians were facing cuts every year, for their for what they did, because a lot of our patients are Medicare patients that and how we're reimbursed. Well, it seemed to be that in 2015, the Medicare Reauthorization Act was passed, otherwise known as MACRA, and that was looked at as a victory. It's to take us away from the sustained growth rate formula way of paying physicians through Medicare. The problem is that it added to a significant burden in quality metric reporting, the paperwork, and the clerical burden placed on physicians after MACRA became law in 2017 made it much, much more difficult for independent private practices to continue working, because you were expected to do the same level of work, but now you're expected to add to this the reporting of quality metrics that you had to manually enter into databases, do practice improvement projects, make sure you were still complying with the electronic health record meaningful use program. So it's interesting, if you look at the number of practices that got bought out or consolidated after 2017, it went up because of these clerical burdens. And so that's a major challenge, because the cost to comply with a lot of these initiatives is not low at all. And the cost of having a practice continues to go up, whereas reimbursements continue to go down. So since we were talking about food, I'd just like to think about this as being a guy who made pizza and owned a pizza shop. And then customers having pizza care and getting their pizzas through that route. Well, if you can imagine pizza care dictating what ingredients you had to use and your need to submit quality metrics that your pizzas reached a certain quality level, that certainly would take away from the quality of pizzas that could be made by this pizza maker. Well, the same issue is happening with physicians, particularly those in private practice, when we're being told what we can prescribe, what we can do for our patients, when we can see them, and obviously how much we get paid.
And what would life look like without that clerical burden for yourself as someone running a business, but also for your patients?
Well, I'd be able to spend more time in front of the patients instead of in front of a computer. In fact, data has shown that for every hour physicians spend in front of patients, there's 2 hours that's added that they spend in front of a computer, and that's all tied to the clerical burdens. With that, I'm not going to even go into prior authorizations with insurance, because somebody else can talk about that.
Maybe we'll circle back to that. Thank you. Lynne, from your vantage point as a patient advocate, what systemic challenges do patients face in accessing care from independent physicians?
I'm sure the insurance barrier would be the first one, primary one, right? I mean, patients are choosing their provider typically based on, what the payer has told them that they need to go to, right? So they have to find a provider that their insurance will pay for. They don't necessarily have a lot of options to choose. And then when you add a layer of like a rare disease or a chronic disease patient that's looking for a specialist, those lists narrow significantly, right? So I think, so much of our world where we're choosing, where we're going to go to eat, or, what we're going to buy, we have a lot of ability to be able to research those things, price them, do all of those things, right? When it comes to healthcare, we really don't have that. Patients, there's not always a lot of transparency into like what something actually costs. And patients don't know that information. If your doctor tells you, oh, you need to go have an MRI, you're not going to research all the MRI places in your neighborhood and pick the one that is like the most cost effective. You're going to go say, okay, well, which one does my insurance let me go to? Did my prior auth get approved? Okay, that's where I'm going. And you never even have a conversation about the cost, right? And so I think that's a huge barrier to patients being able to really find a physician that they, can connect and relate to, and that's a good fit for them or their family.
Can you bring this home for us with like a real life example or just an example of someone, like what might they be dealing with? Just get a sense of, what this disorder, how that might be affecting them and how this process you just described might affect them.
Yeah, so specifically with bleeding disorders, again, patients are typically looking to try to get to one of these hemophilia treatment centers. And there are very limited number of them, right? They're going to start at the one closest to their house, but if their insurance doesn't cover that, they're stuck, right? So they might live in the greater Sacramento area, just to give you an example. UC Davis has a hemophilia treatment center. There's, in the Bay Area, there's Stanford, there's UCSF, there's Benioff, right? There's nothing further north from that. Right? Nothing further north from that. So you're talking about patients then either having to go to Oregon, if their insurance will allow them to go to an out-of-state physician, or drive all the way down to the Bay, navigate Bay Area traffic, or come to Sacramento. And that's kind of funny on the one hand, right? Like, oh my gosh, like who wants to drive in San Francisco? But think about what somebody who lives in a little tiny town in Northern California. Think about whether or not they can afford the gas to get there, and think about whether or not their car can even make it, right? And so that's where if they can find a physician that's local that can at least collaborate with that provider that has the expertise that they may not have themselves, that could be a huge benefit for them to not have to make that trip as frequently.
Well, not to mention the opportunity cost of the time, and this person is in pain, and they have so much else going on,
Right.
and to take a full day to get out there, and maybe not get the answer that you want, right?
Right, and additionally, I will just add this. It's very likely that the hospital that's near them doesn't even carry the medication that they need. So they can't even go there in an emergency and get treatment, because it's unlikely that the med that they take is at that ER.
Thank you.
Yeah.
Dr. Deen, I want to talk about the barriers that independent physicians face in balancing the dual responsibilities of providing care and also running a business. What's that like for you?
Give me about 3 hours for this answer.
We got about 7 minutes.
Okay, so I'll try to be concise, but there's so many points I think we need to hit. I'd like to start with most patients are not aware of how physicians are reimbursed, how we're paid. Having insurance is not the same as having good coverage. Unfortunately, physicians are often vilified for not accepting certain insurances or certain patients. There is competition in the marketplace currently with payers, but the competition is to see who can get you to accept the least. And when you're running a business, like any business, if I'm getting the product for $20, I can't sell that product for less than $20. I just can't. We are at a point where we are selling that product for anywhere between $15 up to about $20.50. It really is that bad. When we are in medical school, we are taught to treat the president the same as we would the janitor. We are not supposed to look at insurance. To this day, I don't look at insurance. I have the billers handle that. Because you don't want that as part of the equation when you're treating a patient. Oh, am I going to get paid for this, or am I going to get paid for that? Like, that shouldn't be part of what you do. You do the best you can for the patient, and you test whatever needs to be tested. Most people are not aware that hospitals and health systems are paid a much higher amount for the same exact service that a private practice doctor does. So, and it's not even a different person. If I perform a test or a procedure in my office, I might get paid X amount. If I go to the hospital and do that same procedure in the hospital, they can bill 3X. And that's across the board. There's incentive for the hospital to set up barriers to push me to have to do this procedure in the hospital and not for me to do this in the office, right? Which in itself should be a problem. when all the data shows that private doctors tend to save money, have better outcomes, and have more satisfied patients. Study after study has shown that. So if we were to level the playing field, that would go a long way to at least leaving that choice. I'm not saying every doctor should be private, but that choice should be up to the physician and their lifestyle and what works for them and their capabilities. There's so many variables. But we are in a system currently where every incentive out there is pushing people out of practice and into employed models. It is incentive for the health systems, whether it's large groups or more so hospitals and health systems. From a business standpoint, if you control the patients, you control the revenue. But wait a minute, patients go to see doctors. Therefore, you control the doctors, and you control the patients, and you control the revenue. Once you have that model and that umbrella is set up, then you start incentivizing doctors to do or not do things that are beneficial for your bottom line. And that's what we're seeing. How many tests you're doing, how many procedures. Well, these procedures tend to reimburse really, really well. So then the hospital, and I'm not trying to vilify hospitals, it's business, but then you end up in a position where you find that you are being incentivized to do certain things in higher volume. And patients are unaware of all of this. And when you hear about healthcare cuts, so current physicians, the Medicare pay rate is less than a third of what it was in 1981. I'm not talking inflation, that's dollar for dollar. For every $100 that a doctor could make in 1981, we make under $30 today, right around $30 today. Cost of business, overhead is up, rent is up, utilities are up. We have to pay a minimum staff salary. And so all of those things are what's squeezing doctors out. And so what we're really advocating for is to protect that physician-patient relationship where we are incentivized only to do what is in the best interest of our patients, and no one should be in the middle of that. And insurance companies have just really pushed the envelope over the years, not just through reimbursement, but also who decides what tests I can order. Like, honestly, if I'm being frank, how dare you? How dare you tell me what test I can or cannot do or what you are going to authorize for my patient? If I think this is the best thing for my patient, then that's a decision between us. If I want an MRI, do the MRI. But we have to go through weeks and weeks. And in your field, my colleagues will say that delays in treatment can go weeks or months in that process, and they know that. They know that paying for a cheaper chemotherapy from 1979 that they require you to use before you can use the latest, greatest, they know that more than half of those patients aren't going to be strong enough to tolerate the better stuff down the road, so that's going to save us millions in the long run. We were going to cover it, but we just,
Yeah.
right? And that's something we have to sleep with.
Understood.
Right? So.
Dr. Liu, I see you nodding your head. Would you like to build on what Dr. Deen said?
Absolutely. We're talking about private practice being like a business, and obviously there's going to be detractors that say, oh, healthcare and patient care is not a business, it's a calling. So they exploit our professionalism and our calling to be physicians to help people. Well, my answer to that is if that's the case, well, let's take Wall Street out of the way we care and pay for healthcare. The insurance companies, the large integrated health systems, the way our healthcare is set up in the United States right now, it is definitely a business. But from our end, we don't want it to be a business. We want it to be a calling. But in the end, there's no margin. There's no mission if there's no margin.
We appreciate that. Thank you. We're going to kind of bring ourselves into a soft landing here by talking about some meaningful experiences, some personal stories that highlight the impact of private practice. Lynne, do you have a story of a unique patient relationship with a private practice physician?
So I'm going to go back to something that my dad experienced, right? So this was many years ago now. Unfortunately, he's passed away many years ago. But so with bleeding disorders, you get really bad joint damage, and so he had terrible joints. And by this time, he had contracted HIV through the blood supply, and that was still at a time where even physicians sometimes didn't want to treat a patient with that. And he had an orthopedic surgeon that was a private practitioner here in this area who was willing to do his knee replacement surgery. When the medical device manufacturing rep saw his knee during that surgery, he asked the physician, the orthopedic surgeon, how long has he been in a wheelchair? My dad was not in a wheelchair because many of these folks with bleeding disorders just learn to live with an incredible amount of pain. He was like, no, he just uses a crutch he didn't even use 2 crutches. He just kind of like crutched around with 1 crutch. And those are the kinds of, physicians who their willingness to take on challenges and serve patients make a huge difference for the patients that they serve.
We appreciate that. Thank you. Dr. Deen, can you share a time when being in private practice let you create a more personalized and meaningful experience for a patient?
Yeah, that's actually the funnest part of my job. So in a lot of what I do, so I treat everything from severe malnutrition to issues with digestion and absorption. I have patients on IV nutrition and tube feeding, and then I also have patients that are battling obesity. I also have patients that have eating disorders. It's not a large part of my practice, but I do see these patients. The fun thing in my field is that it's a multifactorial approach. So you're going to have patients with psychiatric issues, you're going to have digestive issues, you're going to have hormonal issues, and so that allows me to collaborate with a lot of doctors in the area. If we decide to go to bariatric surgery, then there's cardiac clearance and things that are required, and sometimes pulmonary function testing beforehand. As a doctor in private, I'm in practice by myself. I have a team set up of dietitians and mid-level practitioners, but I'm the only physician in the group. You get to know the doctors in the area, you get to know their personalities. And there's certain doctors that you think certain patients would best suited seeing. So you might have 10 cardiologists around, but I think this guy needs a little more hand-holding, a little more explanation, and this guy's impatient as hell, and I got this guy is going to be good. And so I can kind of say, hey, look, Mark, I need you to see this guy, and here's the thing, and I can talk a little bit more about it. And I can do that with everyone else, with all the other specialists. So from the patient standpoint, they get exactly the type of team that might suit their personality the best, especially at a time where they're really anxious about what they're going through and a huge change in their body. What comes to mind is I have a patient who's an engineer with Boeing, and this guy is be lucky to get 2 words out of him. He's very and he wants to know how exactly does acid reflux work? Is that, I was reading about parietal cells, is that what that is in the stomach and the antrum of the stomach? And I'm like, all right, pull up a chair, And so you just got to break down the physiology, and this guy's really into that. I have a friend who's a cardiologist who I needed to get clearance from, and I specifically sent him to him because this guy is a nerd, and he's going to sit down and go through all kinds of things. He'll draw out the heart chambers and all that stuff. And it worked out perfectly. And he called me later. He's like, that was an hour visit, but thank you for sending him because he had a great time and I had a great time. And it turns out our kids go to school together. It was the whole thing. So that's kind of the fun part of what we do. And I really enjoy that, kind of being able to bring together a specific team for a specific patient, where in an employed model, I wouldn't have that, whoever's on call is going to see the patient from whatever specialty.
Thank you. So, Dr. Liu, in our last minute here, do you have a meaningful story that you can share about your experience in private practice?
Sure. So often people's cancer diagnosis may be discovered incidentally, and there was a very sweet elderly lady who presented to a primary care office with a cough, and ultimately was found to have a lung mass. And the issue was that the mass was located in a position that was very difficult to biopsy, and it was brought up to the tumor board. And of course, most oncologists will say, well, we can't see the patient until we have an actual diagnosis. And so the next step was to get a PET scan, which helps identify any other areas that the cancer may have metastasized to. But when she showed up for the PET scan, because of her diabetes, their sugar was too high, so they had to cancel and postpone it. So weeks went by, and within the integrated health system there, nobody in the oncology program was going to see her until the biopsy was done. But yet there was this barrier to get to this the tissue diagnosis. So the lung cancer navigator in the integrated health system came to me in desperation, said, is there anything you can do? And so I made the exception and said, let me just see her. Just bring her in, I'll take a look at her. And sure enough, I was the first person to actually do a physical exam on her and felt a nodule right there on her supraclavicular area in her low neck. I was like, that's where you're going to do your biopsy. And from there, she was able to get her diagnosis. But you can imagine if we had gone with the policies that are ingrained in many integrated health systems, this patient may never have gotten the care that she needed.
Thank you. I'm lucky she found you. Well, we're going to transition to questions from the audience, but first, let's hear it from our panelists. So do we have a microphone that we can bring around? Okay, great. Okay, that's great. So we've just got a few minutes for questions, maybe just a few questions. We ask that you keep your questions short to maximize time for our guests. If someone begins to filibuster, I may gently intervene and kind of help direct you to your question. So please, go ahead. Raise your hand if you have any. No need to be shy. There's always a first person. Oh, there's one in the back. There we go.
Thank you again for your guys' time. I'm an internal medicine physician as well, and I've thought about this issue about small practice versus the large groups, and the fact that it's very difficult for the overhead for a business owner, a small business owner, to basically compete with large entities with deep pockets. And I guess my question is, when it comes to this new change with artificial intelligence coming into our EHRs, essentially, potentially allowing us to compete with larger groups by reducing some of that overhead. Do you think that theory is correct, that perhaps there may be a leveling effect of AI being introduced? Because in my EHR, for instance, Epic now, ChatGPT has started to respond to patients by reviewing the labs, and it's conceivable that in the future your medical assistants may just be AI-based, meaning that you may have a much larger team. So my question is, have you guys thought about what that may entail in the future as far as our survival as private practitioners?
Dr. Lugo.
Yeah, sure. I'd say absolutely. There's a lot of potential in helping reduce the clerical burden. I will say that right now AI is still a slippery slope. You hear on the news all the time where ChatGPT makes mistakes, makes up references, and has hallucinations, and so until we can and there's a balance to be had here, because if AI is 100% reliable, well, that definitely will dull the skills of a clinician. If it's somewhere in between, you never know when it's going to be reliable or not. Well, that actually adds to my clerical burden, because I have to recheck what the AI has put out. So at this point, I'm still the main person that's responsible for everything. And so if and when I use AI, it's still, the buck still stops with me. And how much of a burden that's going to be for me to verify what AI has done is correct still remains to be seen.
Dr. Deen, would you like to build on that?
I agree with that, exactly. But I just wanted to kind of take a step back and point out medical records and progress notes exist. They were developed for me to remember what I did for when the next time the patient comes in, number one. Number two, for a colleague or someone else to have an idea of what my plan of care is and what my game plan is. Oh, what was he doing and what was he? Oh, okay, he's planning this and this. It has now become this bloated note, and again, it's dictated by the payers, right? They, for their reasons and their purposes, want specific numbers, specific things, and document all these random things that really mean nothing. When you or I open a note, what's the first thing we do? Scroll to the assessment plan, and you look at, oh, he started azithromycin for whatever. Got it, right? But we're scrolling and scrolling and scrolling and scrolling, right, to get through all of this random stuff. And I think that AI is beneficial, but it's being implemented into a very flawed system And AI, by definition, is going to learn that flawed system and then get more accurate within that flawed system, right? And so that's my fear, is that we're just kind of down the slippery slope of bureaucracy and paperwork that really has no impact on actual patient care, but takes up the majority of my day.
And that's exactly how AI can sometimes perpetrate health inequities by within this, by continuing what the system has.
We may have time for one more question, maybe two. Does anyone have a question? Question right there in front. And I forgot to mention, please state your name and affiliation before your question. Thank you.
Thanks. My name is Ben O'Brien. I'm with California Life Sciences. I guess going off of that question, are there any more immediate solutions that you see to kind of resetting the balance between private practice and these large providers?
I'll just say stop the cuts.
Yeah, I think I'll piggyback off of that. When reimbursement was better, the average physician saw maybe 10, 11 patients a day. Yes, there were some that were seeing a lot more, but there were a few that would just see 3 or 4 patients a day. If you're a busy mom and you want to practice, you want to see a few patients, stay active. But now we're at a point where you are forced to see 30-plus patients a day. I mean, there's really no other way to make ends meet, which means that, and then you think about not every doctor should be seeing that volume. Not everybody is cut from the same cloth and different priorities or whatever. And so, but when you're forced into that, now there's room for error, right? You miss things, it happens. You forget to dot the I's, cross the T's. And so that now is a patient care issue. So number one, the reimbursement, it's not just stop the cuts. We really need to get back to, it's not unreasonable to say we should have a 3 or 4-fold increase in physician reimbursement. But aside from that, there needs to be legislation to get the payers and third parties out of the middle. This should just be, if you come to see me as a patient, that is a sacred relationship as far as I'm concerned, and you are trusting me to do what is in your best interest. But in actuality, I am forced to do what the insurance company will or will not allow, especially with some of these capitated agreements with insurance payers. They will pay you X amount, whether you test 1 million things or you don't test anything at all. So you are ultimately incentivizing me to not do tests and not look for things, which is not fair and it's not appropriate medicine. So it's just an example.
We've got about 2 minutes left. Does anyone have a final question to bring us home? Thank you. Please state your name and affiliation.
Jeannie Kane, Kane Strategies. My question, I don't need the mic. My question is, So my question is, in the rural areas where health plans are required to have networks by law, doesn't the small group practice and independent physicians have the leverage, putting aside Medicare, because those are fixed rates, to negotiate higher rates with those health plans? And if not, why not?
That's a great question. What a lot of if there's a practice like ours in a rural area where we may be the only specialty in town, we actually choose not to have a contract with them. It's actually better because to not have a contract, because when we do, even if we're able to negotiate better rates, there's always this clause in the contract where that after 90 days, they can reimburse you whatever they want. And so that was experienced with our practice as well. After about 3 months with some of our private payers, we what happened? Oh, and they said, oh, there's this clause in your contract that allows us to pay whatever we want afterwards. So this was actually before I joined the practice. This is what my senior partner had told me. And so since then, we've been operating without a contract. And so we basically have to play this game with the private payers, saying, okay, our patients that see us that have that payer get nasty letters from the insurance company saying your physician is not within network. And then we have to file this appeal. And so our biller actually knows exactly how to do this to say it's unfair to make a patient travel 3 to 5 hours to seek a physician that's within network. So that's how we're able to deal with that in rural areas. Unfortunately, those in much larger cities don't have that leverage. And so they're forced to accept reimbursement rates much lower than Medicare.
So just to add to that, so like in larger cities, what we're seeing is that, and I'll give you a real example, there's 2 big groups in town, and there's 2 HMOs that have 2-year contracts. One is with one group and one's with the other group. And every 2 years, each of those guys will go to both groups and say, you want to take this crappy deal? And they'll say, no, why would we take that? Oh, really? Because these guys are ready to take it. So, and then they'll go and do the same thing and literally drive down. They're getting paid less and less every 2 years. And that has an impact on patient care, of course, right?
You all have been sorry.
I just really
please.
quick, like in relation to that story, I recently had a patient contact me, happened to be in a rural area. She needed to have a test run. She went to the hospital that she always has the test run at. It's in network, under her coverage. And they said somehow it ended up getting flagged over to the billing department. The patient was told, well, we'll do it this one time, but we're not doing it again for you because we lose money when we run this test.
Okay, thanks everyone. This is our second panel on barriers to private practice. Let me introduce our panelists. Dr. Lamia Gabal is a distinguished urologist and a leader in her field. She is board certified in female pelvic medicine and reconstructive surgery, and she practices at Prestige Medical Group in Orange County. For the past 17 years, Dr. Gabal has been recognized as a top doctor by the Orange County Medical Association. Well, welcome, Dr. Gabal.
Thank you.
Dr. Flo de Benedetto, JD, is the president and CEO of Benedetto Solutions, Incorporated, in Roseville. From 2008 to 2023, she served as senior vice president and general counsel at Sutter Health, where she oversaw a department of 360 people with a budget of $85 million. Welcome, Flo.
Thank you.
Dr. Michael Leathers is an orthopedic surgeon and a sports medicine physician based in Sacramento. He specializes in advanced knee, shoulder, and hip reconstruction, as well as shoulder replacement for arthritis. His steadfast dedication to improving health and performance benefits everyone from professional athletes to weekend warriors. Dr. Leathers, we're happy to have you. So today's conversation is going to shed light on some of the obstacles faced by private practice physicians. Let's dive right in, starting by discussing the biggest challenges in starting and maintaining a private practice. These challenges can include regulations, administrative work, navigating insurance, we've been talking about that, and competing with larger systems. Dr. Gabal, can you tell us how you got into medicine, your current role, and how your practice offers patients something they might struggle to find elsewhere?
Yes. So I came to this country at 2 years old, not by my choice, but my parents, and they came here from Egypt for better opportunities for their children. So I grew up basically wanting to be a physician to help people, right, and to take care of them and to have people live healthier lives. When I first went into practice in 2001, that was much easier. I joined one other urologist in practice, and for the two of us, we had 2 front office people and 1 back office nurse. And that was very doable. We were a very busy practice. And we were able to help people. We were able to make our own decisions. And fast forward now, you've heard some of the same frustrations from my colleagues earlier, but I have built a practice that I'm very proud of. There aren't very many female urologists. When I finished in 2001, only 4% of board-certified urologists were women. We're now up to about 11%. Woo. And I tell my male patients we have smaller fingers than the guys, so good reason to have a female urologist. But we do see both men and women. But now, in order for me, I have another physician who works for me. I have 2 PAs. And so for 4 providers, it takes a staff of 16 people to support us, in addition to my billing service, which is outsourced. And so, not only have reimbursements come down, but the ability to run your own practice has gotten more complicated. And I, in fact, have another woman who's joining me, so there'll be 3 female physicians female urologists under one roof, which is also pretty rare. She's starting in January, but she's coming to join me now because she's been on her own for many years, and it's just not tenable. She can't do it on her own anymore with her small office and her small practice with 1 or 2 people. So she's joining me, and hopefully to consolidate and be able to give better care to patients. But the patients are the ones that get hurt in the end.
Thank you. Flo, I kind of hurried through your biography, so if you could remind people of what you do, how you got into healthcare, and how your experience has shaped your view of care.
Sure. I got into healthcare about 43 years ago. I started practicing law in San Francisco in 1981. I was a trial lawyer, and so I was trying cases anywhere from product defects in airplanes to families arguing over will contests, et cetera. And one of the senior partners in my firm handed me a Medi-Cal cost reimbursement case against a provider. A provider was bringing it against the Medi-Cal program and said, "You have to try this case." And it was so complex, and this was 1985, so a long, long time ago. It was so complex at that time, I had to literally go back to school and take some financial management of hospital cases or studies to come to understand just the entire reimbursement system. And I would tell you that was how many years ago. Today, in those days, we probably had 2/3 of the regulations that we have today. So that got me interested in healthcare. I stayed in school. I got an MBA in healthcare management and decided that this was an area where I might actually be able to see a difference that being a lawyer could make in the lives of people. And so over the last 43 years, I was in private practice for 28 years, representing mostly physicians and medical staffs, both large group and independent physicians. And then for over 14 years was the general counsel, which is essentially the chief legal officer of a $15 billion enterprise, Sutter Health, that has a number of large affiliated medical groups and also some aligned independent physicians. So I've seen this industry from both sides.
And so let's talk about that from your experience representing and advising healthcare providers. What's a systemic challenge faced by private practice physicians?
Well, you've heard some of them already, but I would say that, and one of the prior panelists kind of ended his comments with no margin, no mission. I think the biggest challenge I've seen for independent physicians is dealing with insurance companies because, and I would invite the persons who work in this building to impose as much scrutiny on insurance companies as I've seen imposed on providers, whether it's large providers versus smaller providers. But these contracts are hugely, hugely complex. They're at least 85 pages, if you can believe that. And it takes a specialist to truly understand them. And they're presented to independent physicians as well as large group practice physicians, basically on a take it or leave it basis. Now, if you're affiliated with a large group practice that's affiliated with an integrated delivery system, and there are several in this city, not just the one that I worked at, you've got a whole team of people that handle those negotiations, that know how to negotiate, that know how to bargain, that have the time to do it, which these independent physicians don't have. But if you're on your own in independent practice, you don't have that frankly, that leverage. The payment rates, as you heard, are vastly different for no good reason other than the independent physicians don't have the ability to negotiate higher rates. And then you've got the other types of provisions, like we've alluded to prior authorization. What we didn't allude to was the ability to retroactively deny after prior authorization has been given. After the physician has treated the patient, the insurance company will come in and retroactively deny it, which means the independent physician doesn't get paid, and who bears the bill is the patient. But the patient doesn't necessarily understand that it's the insurance company. They're mad at the doctors because now they have a big administrative burden. And I think in the future, you're just going to see rates continue to decline, and yet the cost of the labor to run these practices, the capital infrastructure that's necessary to have the IT platforms that you need to have to do all this data collection and reporting it's untenable.
It sounds really scary. From a patient's perspective, how do they respond when that kind of thing happens to
It's
them?
an enormous amount of frustration, and I'm a patient, obviously, as well as a physician. I lost my independent GI physician who had to go out of practice because they weren't making enough money to keep the practice going, couldn't recruit other doctors because they couldn't pay them what some of the larger affiliated healthcare systems could pay. And it took me 18 months to find another physician in a large group practice that would see me. So, and one other thing I'll allude to, Alan, is we've talked a lot about how the competition is largely focused on large healthcare delivery systems. What most people in this room may not realize is that insurance companies are now also purchasing physician practices and getting into the provider space so that they're controlling both the payment and the provider. So you've got Blue Shield's got their own Alteus subsidiary that has purchased a large group practice in San Francisco. United Healthcare has Optum. Optum's been gobbling up medical practices all over the country. So let's take the time to take a close look at what's happening on the insurance side as well as on the provider side, because I think the biggest systemic challenge I see continues to come from the insurance side.
I want to circle back to that because I'm curious about how that affects patients and other providers. But Dr. Leathers, can you give us a few sentences on background on yourself and how you provide a service to patients that they may be challenged to find elsewhere?
Yeah, thanks. Flo, what you said was really good and well said. I want to
Spot on.
very spot on. And as well as the first panel, a lot of very great things were mentioned and said. And in terms of what I think I provide patients is building a good trusting relationship. I'm an orthopedic surgeon. A lot of patients come in and some need surgery, some don't. But when you make an appointment to come to my office to see me, you get to see me. You aren't seeing, and it's just the way I structured my practice is my choice. I don't have any advanced care practitioners. You get to see me. If we decide that you're going to have surgery, all of your post-op appointments are with me. And that's important because that's the way I think I can deliver the best care for the patient. And I know in other big box healthcare systems, you're not always going to see the surgeon. And when you do, sometimes it's on the day of surgery. That's the first time you met your orthopedic surgeon to get your Achilles tendon repaired or your rotator cuff repaired because they're trying to be efficient. They have so many patients to take care of. They're just trying to crank through everybody. But I don't think that that's the best way to deliver care. I don't think that builds trust. And in turn, I don't think that's how patient satisfaction is going to be improved or build better patient satisfaction.
And then kind of stepping back, we've been talking about multiple challenges, but do you want to build on something that's already been said or mention a different challenge, be it administrative burden, we've talked about insurance, or competition with larger healthcare systems? What's a real tension point from you?
Well, just what Flo is mentioning is, as an independent practitioner, when I showed up in town 7.5 years ago, I put in my application with each insurance company, and they took about 6 months to sometimes a year, depending on the carrier, to actually get onboarded with them or get a contract with them. And it was like, here's your rate. Oftentimes it's listed as a percent of what Medicare reimburses, 80%, 70%, 105%. But this is what it is, take it or leave it. Okay, but then sifting through the pages to actually find that rate, they do it on purpose. We're physicians, we're there to take care of patients. We're not there to negotiate prices. And if I say, well, I don't really want 85% of what Medicare reimburses, I think I should get at least 100% or maybe 105%. They would say, well, that's not what we're going to offer you. Therefore, you won't have access to our patients then. And to this day, 7.5 years ago, I haven't gone back to the carriers to try and renegotiate because there is no negotiation. But you hear multiple times, and sometimes this makes the news, but I hear about it, is that certain large group payer systems will get dropped from UC Davis or Sutter Medical Group or the Sutter System or whatever large institution you might have in your area. And it's because they're negotiating rates on behalf of all the physicians there. So it's cheaper to come see me for a same problem, rotator cuff tear. It is cheaper to come see me than it is someone at a larger healthcare institution because they have people that can negotiate on behalf of their physicians. And so that's one frustration. We talked about the authorization for MRIs. Just being able to do your normal day-to-day activities is challenging. So.
And have you talked to your peers about what, without getting too much in the weeds or granular, have you talked to your peers about what solutions could look like on that?
That's why I'm relying on PAC to help to come up with some good solutions and then help with on the legislative part of it, I think is important.
Thank you. Now that we've identified some barriers, let's explore how they impact the providers and the patients they serve. Dr. Gabal, can you point to one of the hurdles that we've pinpointed and explain how it affects your private practice sector at large?
Yeah, so I can think of several stories. Patient access to care, which has been very difficult. Getting to a specialist, sometimes people have to jump over hoops and they have to be their own advocate in order to even get to a specialist. And so there was one particular insurer who happens to be, I'm pretty sure they disincentivize their primary care doctors from referring to specialists. And so this man, late 50s, had been seeing blood in his urine for over 8 months and finally got the authorization to come and see me. And so by that time, I diagnosed him with a muscle-invasive bladder cancer that required removal of his bladder and living with an ostomy, a urostomy, kind of like a colostomy for the rest of his life, if it was even curable at that point. And whereas if he had come to me 8 months sooner, the first time he saw the blood in the urine, it could have been cured by a simple scope surgery, going through the urethra, scraping out the tumor, and then surveillance after that. And I feel like insurance companies think that they're saving money, and maybe they are saving money in the end if the patient dies. I mean, that's truly, they don't really care. And so they think they're saving money by delaying care. And in the end, who is it who suffers? The physicians definitely suffer, but it's the patients. It's really the patients. And, I'm a mom of a 20-year-old now who has also a chronic medical illness. And so I see it on both sides. As the mother of a patient, as a physician, it's frustrating. And just getting access to care, whether you're in a rural area or not, having the insurance companies limit who you can see, when you can see them. And so we're trying to develop some other avenues in our practice, to help patients focus more on health and not treating illness, maintaining health. Mm-hmm. And I think a lot of our American insurance-based medical care is really based on treating illness. But if we could focus more on maintaining wellness and maintaining health, I think that's better for everyone. But insurance companies don't pay for that. And so, it doesn't help their bottom line. And so really what we're doing is trying to develop these programs for our patients that are elective, people who can afford to do things around their insurance companies, outside of their insurance. But not everyone has that.
And that devastating story you told about that patient, how common is that kind of thing across the industry?
Unfortunately, it's more common than people realize. By the time the patient gets to see the person they're supposed to see, the hurdles that they've had to jump through, the months and weeks or months of delay. And then not to mention, once they do get to me, how do I get them to another specialized? Because, in the community, none of us do those big surgeries anymore. The cystectomies, the removal of the bladder, it really does have to go to a university setting. But to get that insurance company to approve him to go to that, that higher level of care also takes weeks to months. And it's just so frustrating for everyone involved. And again, the insurers are just really hoping that they, they don't really care. It's not on them.
Flo, let's move to you. What's a major legal or administrative challenge that you see private practice physicians dealing with now that may get worse over time?
Well, I still think that the largest issue that we're dealing with is the growing control by insurance companies, which I would submit, having been on both sides of the healthcare equation here as both an in-house lawyer for a large integrated delivery system and also in private practice representing a number of independent physicians. It's going to be the growing influence of insurance companies and their now entry into the provider side of the healthcare equation, I think we're going to see more consolidation of large health systems over time, especially with the results of the election. I think we're going to see less, I don't know if it's going to be less antitrust scrutiny, but the incoming administration is certainly more business friendly. And that's not necessarily a bad thing, but I do think we'll see continued consolidation of both insurance companies and continued consolidation of these larger systems and the larger medical groups. And on the insurance company side, I should have mentioned earlier, it's not like they pay these physicians within 30 days. Oh, no. Payment can be delayed for 6, 8, 12 months while they argue over line item things on the physician's bill. And then they get into a dispute about it, and then the dispute can take anywhere from a year to 2 years to resolve. I happen to be an arbitrator for the American Arbitration Association. A number of the arbitrations I'm handling are between providers and insurance companies. And the care in the cases that I'm handling right now was provided in 2018, 2019, 2020. That's how long it can take. I think another challenge we're going to see is, and someone alluded to this on the prior panel, it's really important for people who are making policy to understand how the money flows in healthcare and the different ways that these independent physicians are paid. They are not all paid on a fee-for-service basis. You do this X procedure, you get paid this amount, no matter how small it is, and it's much smaller for the independent physicians. There's also something called value-based care or capitated care, and a lot of people don't understand what that is. The provider, whether it's a physician or a hospital, gets X amount of money, and you are now responsible for providing all of the care that that patient needs for that flat rate. And that minimizes the insurance company's exposure and maximizes the risk to the physicians. And that might sound enticing, but the challenge for independent physicians is they don't have the access to capital to purchase the infrastructure to gather the data and analyze the data to manage the total cost of care for that patient. So I worry about where the reimbursement field is going with this increase in what we call risk-based reimbursement and the impact on individual physicians. And I just see this, look, rates are not going to go up in my lifetime. And probably in most of the lifetime of the people in this room, rates are going to continue to go down. So something has to be done, I think, legislatively to address rates, to address insurance company control, to address what the prior panelists talked about with all of these administrative hurdles that really have nothing, if anything, to do with taking care of the patient. And let's look at the profits that the insurance companies are actually making. No one looks at the profits, not federal, not state, not the media, but you look at the amount of money these insurance companies are making in terms of profit, and it's impressive.
It's obscene.
Thank you. I'll stop now.
Dr. Leathers, do you want to build on what Flo talked about and give us kind of a viewpoint from a practicing person and in communication with other peers in your field about insurance consolidation or rates?
Yeah, I would just touch on, say a couple things and follow up. I think Flo said it well, but I would say, what we do in private practice is we provide a lot of access for patients. We, get patients in quickly, efficiently, and it's not that the other institutions can't do that either, but it's kind of like we're that small business, the local store in the neighborhood. We know the people in the area. They can call us at home. They can call us on our cell phones, et cetera, and get in quickly. They can call my office. They're going to get someone. And if we aren't there, that access will go away. And we will all be going to larger institutions which do deliver very good care. But you're going to wait, and you're going to follow an algorithm, a protocol. And I don't think that as Americans, that's what we look at healthcare as. I think we're used to something different, and I certainly think we want something different. We want to try and keep what we have in private practice because, again, it's about trust. It's about building a relationship with the patient because that creates, good patient outcomes, patient satisfaction, but also it makes the physician happy. We feel good about what we do. We have skin in the game, that was mentioned earlier. We're going to be around. We're not going to go anywhere. That's why a lot of people probably in this room have had primary care doctors for 20, 30 plus years. But there's also probably people in this room that have had a primary care doctor for a year, and then that person left, and they're on to the second, third, fourth person. And it's just this carousel, and it's, well, why is that? Well, the physician's not happy. They don't like being in that type of managed big box institution. And so it's important to protect private practice so that we can provide access for patients, provide that care that's personal.
Thank you.
So the administrative burden part, I didn't talk about that. But I mean, it's incredible, the restricting of care that goes on. I mean, there could be, when a patient comes in, they see me for certain diagnosis standard of care is to get an MRI. It's not really up for debate. It's like the standard of care. Well, I have to document that, meet certain requirements in my documentation to get that MRI authorized for their shoulder. Well, it'll oftentimes get denied. And it was like, well, did you see my, and then it's just back and forth. And of course, it always gets approved. It always does. I've never once had an MRI not get approved after I kind of put my foot down. It gets approved, but it's after a week or two, and I actually have to get on the phone and do a peer-to-peer to speak with another physician about, and they're very nice, cordial, and like I said, it gets approved every time. But what if I didn't have time to call, after hours, during my lunch break, between surgeries? I just said, I don't have time for that because I'm taking care of another patient. Then that person's not going to get their MRI. And that's what they're hoping for. They're hoping I don't call or put my foot down to try and get that MRI approved. And so that's how they restrict care. And that's frustrating. Those types of burdens make it frustrating. It leads to physician burnout. That's why we're losing private practice doctors because of stuff like that.
So given that, I want to kind of look for some lights at the end of these tunnels. And I'm going to open up a question, just whichever of you would like to respond to it, is what strategies or innovative approaches have you used or seen others use to navigate the challenges that we've been talking about to run a business or just stay competitive in this landscape?
So I think, as I stated earlier, just about trying to develop these other elective types of treatments for regenerative health and maintenance of health, as opposed to treating illness, trying to prevent illness. And again, those are more elective and outside of insurance.
Flo, how do private practices stay competitive and viable in such a regulated space?
Well, I think the reality is that increasingly they're not. I would be the richest consultant in the state of California if I had a silver bullet for that. But what I've seen independent physicians do is, a lot of them have joined what's called independent practice associations. These are large groups that actually negotiate with insurance companies on behalf of their individual members. And the physicians are able to maintain their independent practice, but they allow this IPA to jointly contract with insurance companies for them. That gives some relief, not a ton of relief. I have seen some of our health systems in Northern California be more open to having professional service agreements with individual physician groups as opposed to the large groups. I see that as maybe an opportunity for independent physicians to be able to align, not affiliate, but align with larger group practices or larger integrated delivery systems by having their own individual contract with the health system. That's a possibility. Beyond that, honestly, I think to put the burden on the physicians to say, you guys figure out how you can be more competitive in this playing field that is very unequal, because you've got the strength of the insurance companies, who again are now coming into the provider space as well as the payer space, and the large integrated delivery systems, which do provide value and a service. I worked in one for 14 years. These are well-intended people trying to do the right thing. But because of the resources that are available to them, they do have the ability to subsidize some of their affiliated medical groups. If you think these large medical groups could make it on their own, they would not. They are subsidized to one degree or another by the organizations, the integrated delivery systems with which they're affiliated. Again, not a bad thing, but even these large groups need help. We have to figure out as an industry, and if we get the right people in the right room, truly committed to taking care of patients, and truly committed to looking at the agendas and motivations of everyone in this space, we would come up with solutions like, how do we subsidize independent physicians to be able to get the infrastructure and the technology they need? We can talk about AI all we want, but most of these independent physicians don't have the money to pay for the IT platforms to drive the AI. How can we subsidize them? How can we make recruitment loans available to them so they can recruit physicians into their independent practice? The hospitals can do it with their affiliated medical groups. Who is there to give recruitment incentives and subsidies to independent physicians? How do we, again, level the playing field with the insurance companies and get these physicians better rates? So we can brainstorm what independent physicians can do, but the reality is there are more opportunities for some of these other players and for the policymakers here to make a difference in how these physicians practice.
Dr. Leathers, I'd love to hear how you have navigated, these various pressures and challenges and used your personalized care to maybe give us a patient success story, maybe lighten us up a little bit.
Well, this just happened a month ago. I mean, there's lots of stories, but just a month ago, I got a call from a mother. Her son had broken his arm about 2.5 weeks ago and was in a large, this again, more contrasting, why private practice, what I can do in a smaller, nimble organization like what I own and operate versus a larger group system. She was stuck in that. The son saw an advanced care practitioner. By the time they got to the orthopedic surgeon in that group, it was 2.5 weeks later, and the physician just said, well, the fracture should probably heal. It'll probably be okay. And so then I get a call from the mother, calls my assistant, and my assistant goes, I think you need to talk to this mom. So I get on the phone, we talk, we discuss, I'm able to look up the x-rays. I say, well, why don't you bring him in this afternoon? I had him in surgery the next day, fixed it. It was no big deal. He's healed, and he's doing very well at this point. And this is about 6 weeks ago. So I just took the cast off, and the bone is straight. And if I was in a larger institution, I probably wouldn't have that flexibility to do that. But that's my choice. No one's telling me how to run my practice, and I can do the right thing for the patient. And so that's the benefit that there's a lot of really good things that happen in private practice that we can deliver great care for patients, and it's because we're nimble. We try to be efficient, keep our overhead and our costs low. It's hard. A question was brought up earlier about AI and using technology. There's a lot of cybersecurity a lot of money has to go into that to make sure that it's safe. It protects patient information, and it's hard for a small private practice to absorb those costs.
I think that's a great place to close. I'm glad that young person got the help they needed. We're going to open up once again for questions from the audience. Please state your name and affiliation. We have a question in the back.
I'm Joey Liu. I'm a radiation oncologist in private practice. We're seeing a lot of large integrated health systems and payers install chief quality officers or chief compliance officers, and the move towards quality. Do you all find that there's a disconnect between what payers and large health systems view as quality versus what patients view as quality? And in your role as an independent physician, do you feel like you can deliver on that better?
If I could take that question, please. When business people start making decisions for what is quality care, I think that is when we have to be really suspect. Because, they're going on business metrics, And they may consider this MRI not being quality care, when in fact it's the standard of care for what the type of, the top-notch medical care that we're trying to give to our patients. And so I think there needs to be more physician oversight in these panels. I think there needs to be more realistic goals on these panels where they're setting these metrics you spoke to earlier about macro, where, as a urologist, I'm expected to ask these questions just so I can check a box that have nothing to do with the care of my patient, because otherwise, then I'm taken down 9% from the already decreased reimbursement that that I have to accept. And so, it's super frustrating, on all of these levels. But yeah, quality care, the definition of quality care really needs to be looked at, because it's not the definition I think that patients would give it, and it's not the definition that we as physicians would give it.
Would anyone like to build on that?
Well, I would agree with that and say that you can talk about clinical outcomes, and that's certainly something that feeds into quality, but let's look at the entire patient experience. I think it was Dr. Leathers who said, if you call a large medical group that's affiliated with an integrated delivery system, you're actually not calling the doctor. You're calling a call center. And I will just speak for myself. I have no ability to actually call my primary care physician. You can't get to the office. You get to the call center, maybe, and then eventually maybe your note gets to the doctor, maybe. Probably not. So I think you have to look at the whole patient experience in addition to the clinical outcome, because I think the patient would define quality by virtue of their entire experience. And that entry point, the ability to call Dr. Leathers and he answers the phone, or I had the cell phone for my private practice independent GI. When I was having a GI flare, I needed to get to the doctor. That's a huge part, I think, of quality care.
Thank you. Question right here, in the front. I saw it first.
Hi, Deborah Ferris, President of Practice and Liability Consultants. What do you think is going to happen with Dr. Oz and RFK, being in charge? And I see that physicians are going to have to spend so much more time explaining vaccines, and Medicare Advantage plans. That's a whole thing.
Disadvantage.
Yes, exactly. Well, I have my thoughts about it, but what can we do? Because this is going to impact private practice even more, because they're going to have to spend more time explaining all this stuff to patients. What do you see we can do about this?
Oh my, it's so disheartening to look at what lies ahead for us. The job is going to be harder, and to get paid less to do more work. I mean, that's not tenable. It's just not. That's why so many physicians are leaving medicine, not just private practice, but medicine as a whole. And our country is going to be, in dire straits after a few years, trying to just find people to administer healthcare. So I don't even know how to answer that, Deborah. It's a great question, and it's very depressing. It's
very deeply concerning.
I know.
I'd say, I guess I would say that kind of comes with the job. I mean, we signed up to be physicians, to be educators. We don't really tell patients what to do. We just try and provide as many facts as we can and provide all the information so the patient can make the best choice for them. So whether it's vaccines coming into question, or the latest one I've gotten over the last few months is about peptides. A lot of trainers in the gym are talking about peptides, and so I get a lot of questions about peptides, and I'm like, what do you think about that, doctor? I go, well, I haven't heard a lot about it, and there's probably a reason why we haven't heard a lot about it. So it might be from Dr. Oz, it might be from whoever, and the reality is it's always going to be something that comes up and you have to just go back to our training, the standard of care, what we learned, and just to provide education. And that's how you combat it. But that's what we do every day. We just educate patients and help them make the best choice for them.
Hello?
I would just say that I I think we can all be very depressed looking at the future for a variety of different reasons. But I think what I hope we can come out of today with is a commitment of the group of people that's here today to really attack the nuts and bolts of what we've been talking about and figure out 1 or 2 or 3 things that we want to get done in 2025, whether it's legislatively or whatever it is, to begin to ameliorate some of these barriers that we've talked about that are raised by insurance companies, or to enhance some of the financial support for independent physicians. But let's focus on the nuts and bolts and the 1 or 2 or 3 things that we can do. Whatever's going to happen coming out of the federal government is going to happen, but we know what's in front of us right now, that we could, if we brought the right people together, really committed to taking care of the patients and keeping the patients at the center of our healthcare system, we can address some of these right now in front of us issues.
Is there any chance that 2025 could create greater opportunity for reform with disarray at the federal level?
I'm not ruling it out. I'm not ruling it out. So, but I think we just have to see what comes. But we know what's facing us right now.
If I could speak to a little bit to that point about what is facing us right now, and I just would like everyone in this room to understand better some of the other challenges that we meet as, trying to run our own business, run our own practice, and still see patients, and you alluded to it earlier, are the denials from insurance companies. And where, you may already have a prior authorization and you think you're going to get paid for this surgery, but then after, 3 months, they decide they're going to pull the money back because there was something in the documentation that maybe AI found that didn't live up to muster. And so, then that gets pulled back. What they're hoping is that you don't find it, or that if you do find it, you appeal. And then guess what? They will tell you you've run out of appeals. But guess who's in charge of how many appeals you have? It's the insurer. The system is so broken. And yet we have to fight against these giants. They're giants, and we don't have the power. Even the larger groups, I think sometimes they just chalk it up to, well, it's the price of doing business. In any other arena, do people continue to do business when they don't get paid for the work that they're doing? It's just not fair, and it's taking advantage.
There's a question right there.
Hi, Kelly LaRue with Resilient Advocacy, and I think this question is mostly for Flo, and I appreciate you elevating consolidation as part of the discussion. Oftentimes there's well-meaning and well-intentioned legislation around this issue, as there was this past year. How do we increase scrutiny on those that are increasing their power? There's a lot of transactions this year that flew largely under the radar that a lot of people don't even know about that will have an impact on the system. But also make sure that we ensure providers like you all who are doing such wonderful work are able to retain the flexibility to practice how they want with the tools that they need to move forward in an ever-evolving healthcare environment.
So I'm from New Jersey, so I will be very direct. I think where we start is truly educating our policymakers. And it's not going to be a session like this. It's not going to be a whole day like this. It's going to take some time. The healthcare industry is enormously complex and is probably the most highly regulated industry in the United States. And so I think it starts with having our legislators understand how the healthcare system works, how the healthcare dollar flows, the motivations of the various stakeholders, and understand truly by a multidisciplinary review of the impact of the legislation that's being passed, both at the state and the federal level, obviously, not just at the state level. But it has to start there because I think our legislature is very well intended, but they often don't have the knowledge, the education, the experience, the time to think through the unintended consequences of some of these statutes and regulations that get passed, and don't often think about what is really the impact on what should be all of our focus, which is the patient at the end of the day. But I just think it's going to take a very committed effort, and again, I'm hoping today is the start of it, but having people truly understand how this system works, how the various players are motivated, and how we can, I hate to say this, but come together to really be committed to fixing some of these issues. I think that's where it starts.
Well, today certainly is the start of a very meaningful conversation in our new year. Audience, thank you very much for your great questions. And let's have one more round of applause for our panel.
Again, thank you all for being here today. I very much appreciate it. I want to thank the Assemblywoman again, the moderator, and all the great panelists. Our association looks forward to working together with you guys in 2025 and then many years beyond. And with that, wish you a happy new year to you and your family.